Hello class, my name is Megan Parmer, and I'm excited to share with you about the research and findings affecting oncology care. I hope you learn a lot and gain insight on how to improve future care. Let's begin. The healthcare problem that has been personally encountered is an educational deficit in oncology patients, starting with their diagnosis and carrying out to long term. Education and learned knowledge is imperative to making the best decisions. Also, after one makes the decisions, knowledge decreases complications and pain while increasing one's comfort and quality of care. Berger et al., 2018. My rationale for this presentation is because of my passion for the millions of cancer patients and increasing their quality of care. My mother had breast cancer in 2015 and lacked information pertaining to long-term effects, expected complications, and how to manage one's care post-chemotherapy. I was also on oncology floor this summer, and many patients were educated about their treatment and diagnosis. However, many factors such as sexual health, what to expect if side effects happen, and how to decrease pain were always missed. I wanted to study this topic and see how oncology as a whole can improve their educational standard, increasing each patient's satisfaction, comfort, and emotional balance. The purpose of this presentation is to show evidence of how patients learn information more adequately when it is spaced out through their cancer journey, personalized to each individual, and having all topics discussed by the physician and team. As Berger et al. Stated, a well-informed patient is more satisfied with care, has a better sense of control over their situation, and reports a better quality of life. 2018. In Forrester and Blessing, PICO is explained as the population, intervention, comparison, and outcome. The PICO question for this research project is, compared to standard patient educational care, what is the impact of a patient education session on quality of life, needed information, communication, and emotional status for adult patients diagnosed with cancer? The population is patients in oncology struggling with cancers. The intervention is to create a new educational standard by having planned learning sessions to build on one's knowledge throughout their cancer journey. The comparison is based on cancer patients receiving the old standard of care versus the new educational sessions given throughout one's journey. The purposed outcome is to increase patient satisfaction, communication, and quality of life by decreasing their stress and misinformation. To get this outcome, comfort will be assessed through the Kawaba's Comfort Status Scale. Quality in life and communication will be assessed through the ERQ-QOL survey, and lastly, their emotional status will be assessed through the Hamilton Anxiety and Depression Scale. The search strategy databases that were used to obtain the sources were through the PA College Library. Once located, the database that was most crucial is called Launch Summon Discover Tool. This database allows the learner to search key topics and generate the specific timeline, peer-reviewed options, and content type. CINEL, Google Scholar, and Medline were collaborated with to gain some stepping stones. Google Scholar gave great insight on the available topics with oncology. However, Medline and CINEL were very limited and caused blocks in research. Key topics that were typed in on the Summon Discover tool were oncology, cancer patients, treatment and diagnosis, knowledge deficit, quality of life, disease understanding, oncology met needs, and chemotherapy and radiation. In order to determine which articles were relevant, looking at the introduction, methodology, results, and literature review were helpful. If the topic was discussed thoroughly or led to increased confusion, the article was dismissed. Reading results and purpose statements increased knowledge and helped see what the point of the article was. Having a preconceived topic did not allow for unnecessary articles and poorly proven methods. In determining the accountability and validity of each article, reading the researcher's point of view was helpful. Seeing what year and how long the process took, and seeing all the contributing factors helped the decision. If an article had evidence, biases, or poorly cited literature reviews, the source was of no relevance to the study. In finding quality references, at first it was a huge challenge. Many sources were closed and locked without access. This led to frustrations and hardships with finding sources, and increased anxiousness. Second, finding a topic that was interesting and simple was hard to come up with. Once the topic was created, sources were easier to investigate. And thirdly, finding resources that had laid their methods out in a concise and basic format was challenging. Many research articles were jumbled words and hard to decipher into the nursing process. In the end, many sources were found with relevant topics, research and assessment surveys. Despite the challenges, learning the process of article hunting and screening for validity was very interesting. The research method for my first article, Chu et al. 2018, was a 76-item questionnaire created by literature and nurses to assess patients' educational aspects of care. The purpose of the study was to identify the educational needs of cancer patients, see where the gaps of education and information are, and assess if patients are satisfied with their knowledge. 411 patients participated in this study, and the results showed they were satisfied with their knowledge of treatment and diagnosis. However, areas that need improvement are sexual, psychological, supportive, and financial care. In my second article, Berger et al. 2018, the research method was based on the URUC QLQ Info 25 survey. In this 25-question scale was given periodically 3 times after increased sessions of education. The purpose of this study was to assess patients' knowledge of their cancer and treatment plan and to compare it to their satisfaction. 98 either breast or prostate cancer patients participated in this study, and the results were that all patients grew their knowledge after 3 educational sessions, including the lowest baseline scores, and satisfaction of information grew from 53.6% to 73.5%. In my third article, Yu et al. 2017, the research was based on a control and observation group. The nursing education process intervened on one group to test if it can increase one's journey. 4 scales assess their comfort, quality of life, and emotional stature. The purpose of the study was to see and test if the predictive nursing education process can improve oncology patients' comfort, daily activities, satisfaction, and overall quality of life during treatments. 168 cancer patients participated in this study. The results proved that in the observation group post-process, all scale values were improved and their anxiety and depression scores decreased, meaning that the educational process can increase comfort, ADLs, and one's quality. In my fourth article, Coronado et al. 2017, the research was based on the EORTC QLQ C30 survey prior and 3 months post an educational conference of 8 hours of general sessions and 4 hours of breakout groups specific to their cancers. The purpose of the study was to evaluate areas of education and management deficit impacting one's quality of life, symptom burdens, and cancer knowledge. 115 cancer patients participated in this study, and the results showed that the topics of deficit were stress, fatigue, end-of-life decisions, financial burdens, and relationship management. Patients and families experienced information needs. My last source, Pedromos et al. 2015, was based on the Ambulatory Oncology Patient Satisfaction Survey to gauge the experience of cancer patients during the diagnosis and treatment phases. These were mailed to the participants post-cancer diagnosis. The purpose of the study was to assess communication and deficits during the diagnosis and treatments of lung cancer. 17,000 cancer patients participated in this survey. The results proved that the majority of patients had a good encounter with the physician and prognosis about cancer. However, half the patients had anxieties and fears about diagnosis, were not referred to a health provider who could assess and give access to their emotional needs. By having multiple planned educational sessions during one's oncology treatment, communication barriers can be reduced. Berger et al. Lists the barriers to communication such as complex knowledge, poor speaking skills of the educator, not enough time, increased disruptions, and fatigue and stress of the patient. Coronado et al. Adds by saying that limited time with the provider causes patients not to get adequate information, increasing one's stress and anxiety, hindering their quality of life. Chu et al. Completely agrees and states that time restraints limits the educator, causing only critical information to be said. But what happens to the non-critical information? All these factors can hinder physician and patient communication, causing frustration, stress, and poor patient decisions. However, when planned sessions are implemented, one can relax, not be distracted, ask and answer questions, and grow the healthcare relationship. Therapeutic communication and planned education can influence a patient positively and/or negatively about decisions of one's treatments. By having multiple planned educational sessions during one's oncology treatment, all wanted aspects of care can be included, leaving no information out. Chu et al. Explains that patients want information pertaining to their disease, tests, treatments, side effects, sexuality, psychosocial support, and financial matters. After the researchers used the 76-item questionnaire, gaps in knowledge were still in sexual, supportive, psychological, and financial support. Pandros et al. Agrees that there is a deficit and explains that the least known topics in oncology care are disease-affected stress, risk factors, fatigue management, and legal issues, ultimately affecting one's quality of life and relationships. Corrado et al. Also touches on the deficit and explains that after patients were questioned, they wanted more information about their treatments, more time to discuss their options with physicians, and to discuss the impact of travel during their surgery, chemotherapy, and radiation. Not only is it the healthcare's job to cover all the educational aspects, Berger et al. States knowledge about one's disease and treatment is necessary before a patient can consent to further treatments. Improving this research point, providing cancer patients with education, helps patients with decision-making, prepares them for treatments, helps them cope with adverse effects, reduces anxiety and depression, increases satisfaction with treatment, improves communication, and improves quality of life. Chu et al. 2018. By having multiple planned educational sessions during one's oncology treatment, retention of information can increase. Berger et al. Created a survey, and the researchers used this tool to prove that education should be spaced throughout the weeks to increase the quality of education and care. They assessed what patients knew prior to the education and compared it 8 weeks later. The results were incredible, with everyone having increased knowledge, even the lowest baseline patients. By spacing out cancer education, patients can have increased retention. The results of this study can impact clinical practice because patients' levels of knowledge after the 3 sessions climbed to 83%. Chu et al. Also agrees and says that due to a patient's stress and fatigue, too much information can overload a patient. Due to one's emotional and physical effects of cancer and the corresponding treatments, only 20% of information is retained. Why not space out information across the weeks of treatments to allow for questions, increase understanding, and better satisfaction? Not only can teaching increase retention, but written materials and videos can increase knowledge. They can help reinforce oral teaching and enable patients to better manage their health and well-being. By having multiple planned educational sessions during one's oncology treatment, patients' quality of life and educational and emotional status can cultivate. The researchers in Yu et al. And Berger et al.'s articles focused in on increasing education by either using a predictive educational process or an educational plan. This research article keys on how increased education increases satisfaction and one's understanding, ultimately decreasing stress and anxiety. In Yu's et al. Study, 4 surveys were used to assess if the new process can help the quality and psychological functions of patients. During the study, the scales GCQ, QOL, BI, and the HAMA were allowed to evaluate patients' comfort, quality of life, activities of the day, and anxiety or depression that can be caused by and helped through care. In the end, after all 168 participants rated their care, the observation group reported increased comfort, quality of life, and activities of daily living, and their anxiety and depression even dropped significantly, meaning the quality of life through specific care even lifted the patient's spirits. Not only was the implementation of the education positive, specific factors such as a clean room, frequent position changes, monitoring and treating pain, and listening to each patient all simultaneously cultivated a caring atmosphere, increasing one's quality of life and decrease stress, anxiety, and depression. Since both of these comparing studies use surveys to assess one's satisfaction, Chu et al. Commends what patients say because patient satisfaction is an important indicator of the quality of life delivered. In closing of the literature review, not only can nurses and physicians increase this knowledge deficit, but also educate on support groups because they can reduce anxious thoughts and increase a patient's quality of care. The student reflects back on synthesizing the literature for this presentation. It was a long process. The student went through each assignment and wrote all the key points that were needed. After the breakdown of all 5 sources was complete, the work started. The student kept going back to the PICO question and based 4 components to prove the research. After the 4 components were written down, analyzing and comparing the research took a couple hours. It was a simple topic, but many of the sources had similar views and/or vague conclusions. This resulted in reading the information closely and concisely. Some challenges that came up were the time spent, putting various views into 4 topics, and lastly, including and citing the various authors correctly.